We haven't got one, but here we are. And if you're going to examine the right wrist, I'm going to be mainly using my right hand to do the thing, so it's quite useful to be able to kind of be in that position where you can sort of shake hands. So let's have a look at the wrist. So what you're going to do, like always, you're going to look, you're going to feel, and you're going to move. So looking, pretty straightforward. You're going to be looking for obvious scars, swellings, deformities, things like tenosynovitis. Where can you get tenosynovitis in the hand, Mr. Burton?
Well, over the flexor extensor tendon.
Where does tenosynovium exist in the hand?
Well, it pops up proximal and distal to the extensor retinaculum.
Okay.
If you look at the back.
So you can get in three places you can see tenosynovium. One is under the extensor retinaculum on the back of the wrist, and so it will appear proximal and distal to that. One is in the carpal tunnel. It's a rigid tunnel, so it will appear proximal. You might see some swelling here, and the other is in the fibrous flexor sheaths. There's no tenosynovium in the middle of the palm, and there's none in the forearm, so that can't be tenosynovitis. So you need to be thinking about anatomy all the time. So we're looking, scars, sinuses, swellings, obvious deformity, things like tenosynovitis around the wrist. And you're going to be looking for the posture of the hand. Is it supinated? Is there a kappa ulnar type problem if it's a rheumatoid patient? All that sort of stuff. So looking, it's pretty straightforward. Looking at the colour of the hand, you know, things that are really, not really FRCS or level, basic level. And then the bit that people really get a bit confused about is the feeling. And you need to know the bony landmarks in order to feel. Make sure it's not painful, always look at the face. We've already established it's not painful. So, in terms of the landmarks, you need to work away in a systematic way. And what I do is I normally work from radial across the dorsum to the palm. And the standard landmarks, of course, on the dorsum are the listus tubercle, which extensor compartment? Third, where the EPL is, and just distal to that there's a soft bit, and that is the scapholunate ligament, okay? And that's where you need to feel if you're concerned about issues there. Just ulnar to that is the lunate, that's where you might palpate for Kienbock's disease, and just radial to that you're into the scaphoid. And of course the scaphoid is in the anatomical snuff box, but you're not really feeling the scaphoid if the wrist is radial deviated because the trapezium is almost touching the radial styloid. You need to only deviate the wrist to feel the scaphoid. Most people that's painful because there are branches of radial nerve there which are stimulating, so always compare it with the other side. So we're working our way across the back and we're coming to the ulnar. So you can feel the distal ulnar joint, maybe arthritic. You can feel just distal to that in another soft spot, that's the triangular fibre cartilage and the dorsal radio-ulnar ligament. And just ulnar to that is the ulnar styloid. The best way to palpate the ulnar styloid is to put the hand like that, as we mentioned before, because the ulnar styloid is in line with the olecranon. So if you want to feel for the ulnar styloid, where there may be a non-union or some other pathology, that is right over the ulnar styloid, okay? And then we can come round, and you can just about feel in here the volar radio-ulnar ligament, okay? And then moving on to the palm, important things you need to palpate are the FCU tendon, yeah, and then across the palm, or just distal along the FCU tendon is the pisiform. It's just a sesamoid bone within the FCU tendon. We'll come on to that shortly. Moving more along the palm side, scaphoid tubercle, and the other bony landmark is the hook of the hamate. So there's three bony landmarks: pisiform, hook of the hamate, which you can feel if you press hard and is painful, and that might be fractured. Yeah, you can feel that in your own palms, and then just radial to that is the scaphoid tubercle. So if you know the bony landmarks, you can use the bony landmarks to target your examination to individual places that you may be suspicious of injury from history and other things, okay? So you've done the palpation, and now movement, pretty straightforward. Don't forget, if you're assessing forearm rotation, it's all part of the same joint. You must put the elbow into the side to lock it and make sure it's pure forearm rotation. Sometimes people have had long-term forearm rotational stiffness. They have quite a lax carpus, and a lot of the pronation and supination can be coming from the carpus. So what I do is I lock the carpus like that, and I can feel that that's all coming from the forearm, okay? And in terms of wrist flexion extension, as a screening thing, it's quite reasonable to do that, although I think that's quite an inaccurate way of measuring that. In a normal patient, that's dead easy, but you'll notice if you have somebody who's got wrist stiffness, they'll start doing things like not dropping one elbow, and it'll look like it's symmetrical, but it isn't if you're looking at the arms. Similarly, put the backs of the hands together. This is often painful if there's any pathology in the wrist, but you can assess that's nicely symmetrical range of motion, and radial and ulnar deviation similarly. Okay, so that's pretty straightforward. And let's move on to special tests for things. So let's imagine, for example, we're suspicious that there may be a scapholunate ligament injury. And what I would do is I would palpate the landmarks, Lister's tubercle, just distal to that soft point, and that's right onto the scapholunate ligament, and that should be tender if there's an injury there. Everybody's familiar with the Kirk-Watson test. It's quite a difficult test to do. What I would say is always compare it with the apparently normal side. And the way I do Kirk-Watson's test is right hand, my right hand. And the important thing about it is you need to ulnarly and radially deviate the wrist, but it must be purely within the plane of the forearm. So what I'm doing is I'm making sure I'm moving the wrist purely within the plane of the forearm. The reason for that is if you allow a dart throwing motion during this test, yeah, so as you go into extension and radial deviation and flexion and ulnar deviation, the scaphoid will not move. The scaphoid, the proximal carpal row doesn't move with a dart throwing motion. That's all mid-carpal. So you need to stop that. You need to make the proximal carpal row move. And the Kirk-Watson test is index finger on the scaphoid tubercle and feel on the back of the distal radius, and you go from ulnar deviation to radial deviation and pressing on scaphoid tubercle. Now, as you go into radial deviation in a normal wrist, the scaphoid tubercle will be pushing against your index finger because it flexes with radial deviation, yeah? And it should push against your index finger. This is a normal wrist. But if it's abnormal, what will happen is as you radially deviate your wrist, your pressure on the scaphoid tubercle will push the scaphoid dorsally out of its fossa, and that will be painful. And as you release your finger at the end of the radial deviation, it will click back and you might feel a soft clunk. So there's two components to it. There's pain and the feeling that it's going out the back, and as you take the pressure off, it slips back into the fossa and there's a clunk and pain. Lots of people have a positive Kirk-Watson test because they're just slack. Always compare it with the other side, okay? That's scapholunate. So moving along to lunotriquetral instability, we're getting into the dark arts here, really. But again, we know how to feel the lunate because that's Lister's tubercle, just distal is scapholunate, fingers breadth across is onto the lunate, and then a bit further along to that is the triquetrum. And so it's that interval there is what you're palpating. And there are a number of tests for this, but basically they're all the same, and what they're doing is